Great. Good afternoon, everybody. Welcome to this week's AFR case study. We're going to be discussing the agitated patient with Captain Kyle Christian. Thank you, Kyle, for joining us today and having this conversation with us.
Definitely. I'm excited to be here.
Awesome. So we're going to talk about a route 2 for a 12 Delta for an ongoing seizure. Tell us a little bit about the dispatch, what you were thinking when you're on your way.
Sure. So we'd already gotten some information, fortunately, at the station where since I'm on Medic 12, we also run alongside Rescue 5. They had previously been dispatched to 12 Bravo, 12 Delta seizure call at the same address about an hour previous. And Lieutenant Zanone over at Rescue 5 had let me know that this was an agitated patient with them about an hour previous. They'd gotten a non-patient refusal, essentially with, orders to leave their house. So he said they didn't see any seizure activity at that point, but that the patient might have a seizure history, and that was something that might kind of play into this.
It sounds like you guys had some idea of what you were walking into. Whenever I'm thinking about a seizure patient, there's always 5 things that I can think of that can cause seizures. Number one is vital signs. So hypoxia, hypoglycemia. I'm thinking I'm going to get those vitals right away. Then anything metabolic. So did they take something, maybe an overdose, something like that? Is it alcohol withdrawal? That would be a metabolic problem. Pregnancy, eclampsia. So if you're going to a female patient, I always kind of keep that in the back of my mind. And then maybe they have a seizure disorder. They're not just taking their meds. Or it could be a structural problem, like maybe they hit their head, had some trauma, maybe there's a bleed or a traumatic brain injury. Those are my 5 things I'm kind of keeping in the back of my mind as I'm thinking about seizure too. Any of those cross your mind with this guy?
It definitely did. I mean, I think especially being in the Southeast, we see a lot of the non-compliance with meds. We see quite a bit of the metabolic issues that you were talking about, kind of a good array of things where it's always kind of a mixed bag of tricks what we could be walking into.
Yeah. So it's a good idea when you're going to these calls, keep a big open mind about what it could be, right?
Fantastic. That's good stuff. Thanks, Doc. So you guys arrive on scene now. Tell me what you saw, what you did.
Sure. So we responded with Engine 5 on this call. We already had, like I kind of talked about, we had a little bit of an idea what we were walking into. But we walked to a back bathroom of the residence led by the patient's mother, who just said he wasn't acting right. She described some seizure activity where he was sitting in a bathtub and kind of had the petit mal seizure description, lights on, no one's home. But she did also tell us that he was grinding his teeth. So we kind of walked in. He was standing in the bathroom, just kind of staring into space. We addressed him, initially kind of just started with greetings. We were trying to usher him out of the bathroom, just, hey, let's come out to the living room. Let's talk. He walked with us willingly at first, and we kind of kept a couple providers in front of him and behind and kind of had him, surrounded as we walked him out. But he definitely did have some clenched fists. He definitely was acting, not erratically, but just off. We sat him down on a reclining chair in the front room of the residence, and that was when things kind of started to take a turn for the worse, and we asked him to sit down. So.
Awesome. So you see he's protecting his own airway, obviously. He's conversing with you at least a little bit of an agitated posture, but overall still looks stable, not actively seizing when you get eyes on him, correct? Okay. So you get out into the living room, you have him seated on the couch, and you want to take a history. What does he tell you?
Sure. So he actually wasn't responding. He was responding in just kind of incomprehensible words with us, where he was kind of grunting and growling, and he would speak in 1 to 2 word sentences that just, didn't fit the situation. We're trying to get a history from the mother. And it was actually when the mom said that he had a seizure history. He does take seizure medication, but he hadn't had a seizure in the last year. So we were kind of trying to talk to family since he wasn't really talking to us.
Sure. It's always a good idea to get the history from the family if you're not able to get good communication with the patient themselves. So great job on that. So you start your physical exam, you take your vitals. What do you see?
Sure. So we actually did not get an initial set of vitals prior to him becoming agitated with us. Our first set of vitals we actually didn't get until probably 10, 15 minutes into the call when he had already been sedated and restrained. But he definitely was tachycardic. He was hypertensive. He was highly diaphoretic throughout the response, extremely dilated pupils. And really a lot of these things, all we could really do was get a visual assessment at first and get kind of a good idea of, what we were walking into. And then the vital signs fortunately kind of matched his presentation.
So we'll take a step back. So you had an individual, middle-aged gentleman, agitated, slightly combative, just when you initially make contact, not communicating well, and then gets to the point where he becomes potentially aggressive? And what steps did you take once you recognized that, and what did you see?
Sure. So it was actually, we were fortunate to have 6 people on scene, upon initial arrival. If you met a couple of the pipemen over at Engine 5, there were some pretty big guys. We went to go get some vital signs and kind of try to verbally de-escalate and just try to get a blood pressure on him, try to get kind of a mental state. And it was about the time we tried to put the blood pressure cuff on him that he stood up and, kind of had an aggressive posture, hands out, trying to reach out towards our pipemen to, grab them by the shirt. So that was when firefighter Joe Creel over at Engine 5 ended up grabbing him. We were trying to sit him back in the chair. We were trying to physically restrain him in the chair in a seated position. He kind of turned around on us and unfortunately kind of turned himself into a kneeling position on the floor where his head and body were on a reclining chair. His knees were on the floor, but he continually tried to fight us with elbows, was trying to bite at provider hands, was actually harming himself with kind of like rug burns on his leg and on his chest from, fighting to get out of this position. And that was when we made the determination. We had a BSI of 7 at that point. He was attacking people. He was being physically threatening towards us. And we ended up, starting to go down the route of chemical sedation with him.
All right. So talking about the behavioral severity scale, that the index that we see within our Albuquerque Bernalillo County guidelines, and you said that he was a 7 out of 7 on this BSI. So he was essentially to the point where he was physically abusive or assaulting people potentially,
Sure.
Correct?
Sure. So he was starting to kind of take swings at us. He was biting at hands. He was trying to get any piece of clothing he could get with his hands while his shoulders were being restrained. He was trying to grab at clothing and pull legs out from under all of our providers.
So now that it became a safety issue for not only the patient themselves but also the people trying to provide help, what was your frontline medication, or what did you do first?
Sure. So what we had on the truck at the time, we didn't have AS on scene quite yet. So I brought my narcs in with this call, knowing that this could potentially turn into a chemical sedation. I drew up the medication. I drew up some midazolam. I ended up drawing up 5 milligrams to give initially. Gave it in his arm, just kind of the first thing I had available. And then he continued to fight, kind of continued to thrash. I let the guys know, hey, let me know if he starts to kind of get a little bit weaker, his fighting gets slightly less with you. And I kind of looked at the pipemen. They both kind of shook their heads after a couple minutes, and they obviously had pretty tense muscle tone trying to hold him and trying to restrain him from hurting himself and hurting them. So I made the choice to give another 5. This time I actually kind of went in his hip for the second 5. Was still fighting our guys. By the time AAS had shown up, I let them know to bring the gurney in. They had their restraints ready. We ended up physically restraining the patient. He was still fighting and thrashing. Throughout the course of our transport down to the hospital, he received an additional 10 milligrams of Versed across 3 doses, and these 3 were IV. He had 2.5, and then finally just one final dose of 5, where we really had concerns that he was not threatening towards us or not threatening our physical health anymore, but he definitely was twisting his shoulder into strange positions. He was still trying to whip his head around and hit his head on the ambulance walls. It was enough where we were genuinely concerned he was going to hurt himself.
Sure, switch to keeping him safe. That's great.
Yeah, I love how you use the BSI tool to help guide your dosing, and I always think it's a sign of wisdom and experience to start a little bit on the lower end, the appropriate lower end, and then add more if you need to. Once you give it, it's hard to take it back.
Right.
And then his choice with a potential seizure history, it sounds like this may have been more drug-induced.
Sure.
But with a potential seizure history, I think benzos were a nice choice here. With the rollout of droperidol that should be out in the streets right now, I would probably still choose benzos to start with here, just with the seizure history. Sounds like you were wanting some ketamine.
We discussed ketamine. Myself and the 5.5 medic were talking about ketamine in the truck, and we had a similar conversation. And we kind of said, hey, we started with Versed. It seems like it's working. It's just not quite to that dose that we need yet. Let's just kind of keep going with that and see how it goes.
I think that works. It wouldn't have been wrong to add ketamine on
Sure.
either. I think it's okay to mix those two. But I was curious. I was going to ask you. You mentioned that you had brought your narcs with you. What would have happened if you didn't have them with you?
I think that probably would have put our crew in a pretty dangerous situation there, especially with the knowledge that I had where, had I not taken the other crew at their word that, this was a threatening situation for them, then, I think I would have had to leave my guys inside without, as much supervision. And I don't have eyes on the crew that I'm supposed to be keeping safe. I definitely had that, at the forefront of my mind walking into the scene. Let's keep them safe. Let's keep this patient safe. Let's try to keep bystanders safe, because I knew there was other people in the house.
Yeah.
Just anytime we kind of have that, that spidey sense kind of thing, I think that's a good time to just be ready and, be ready for kind of any eventuality there.
To have them with you.
Mm-hmm. Absolutely. It's a great job. And just talk us through real quick about, from the chemical restraint, did you then move to physical restraints, or was he subdued enough where you didn't need them?
We did. So we ended up going with physical restraints still. His fighting was getting slightly weaker after that first 10 of Versed, but this was an unfortunate time. We did put our guys and him in a little bit of a tight spot there where he was still fighting, but we did have to get him up off the floor, up off that chair, and lay him on the gurney. AS did a great job of bringing their gurney in, very close right next to the chair. We essentially just kind of flipped him over where we had a provider on kind of each limb. He was still, tensing and pulling his hands and feet up to kick at us, to fight with us. We did put him in physical restraints, and then it kind of seemed like the physical restraints were actually starting to do more harm to him, which is why we went with further chemical restraint.
And talk about your assessment and treatment after the fact, as soon as you've administered that chemical restraint and the physical restraints at the same time.
Sure. So kind of like I talked about, we initially kind of had a scary situation where when he was fighting us, it was anything we could do to, kind of just get hands on him and keep him from actually harming other people. Unfortunately, that started with him being kneeling but prone in a chair as we were holding him, by the shoulders. We recognized that was a dangerous situation to be in. As soon as that second 5 of Versed had been given, I instructed our pipemen to, flip him over if they felt it was safe to do so. Let's try to get him on his back. Let's try to get him supine at least. Get him prepared to, if we can flip him over, we can just kind of lift him and set him on the gurney. Yeah, there was definitely a concern there where, he wasn't quite sedated enough for us to get him to his feet, and he wasn't cooperative enough, but he was, at least dissociated, I think, to the degree where it was easier to kind of manipulate him and get him on that gurney without as much risk of hurting others.
Managing
involved.
that airway, watching those vital signs, making sure that you're treating the patient, checking the cardiac rhythm, all those things secondary to that as well, right?
Right.
Awesome.
So as soon as we got him on the gurney, that was when we got that IV access. That was when we got him on the monitor. We got him on end-tidal really tried to get a very thorough assessment that we weren't able to get on scene. And fortunately, we were in that nice isolated environment inside of the 5.5 unit where that was, the best environment we could be in to get all of these things. So,
yeah. Sometimes things don't happen in the order you want them to necessarily, but it sounds like you did a good job addressing. He kind of forced your hand and treating him first, and then you knew what to pay attention to afterwards, right? Good. All right. Well, I think you did an excellent job here with using your tools for your dosing. You picked a great medication. It sounds like it was an effective, careful sedation.
Right.
With good attention to the airway. I actually talked to the doctor that took care of him in the ED and said he needed even more sedation when he got to the ED. Came back positive for methamphetamines. Also hadn't been taking his seizure medication as well. So a little bit of both going on. But excellent job. Anything else you'd like to share with providers out there that you learned from this case, or you think younger, newer people could learn from?
Sure. So I think just kind of keeping in the back of your mind, we never know what we're walking into. It's good to kind of have that conversation with your driver, with your crew, on the way to calls. Really any call you go to. What could this be? What are some eventualities? What protocols apply to this? That's a constant communication I've had with a lot of the drivers that I've been fortunate to work with. And then really just doing a debrief after the call. Hey, is there something different we could have done? When did we realize this on scene? What were maybe some of the early indications of what eventually happened? Just really work towards that, that relationship with your crew. Trust your crew, listen to your crew, and fortunately it's had a good outcome. So
outstanding. Remember, safety is always paramount, so we want to take care of ourselves before we can take care of our patients. So you guys did a great job of doing that. Thank you, Cap, for sharing your story with us. We appreciate it. There's more to come in terms of safety that Doc and I want to roll out from the division, but if anybody else has any interesting cases they want to share, feel free to reach out to us at the SharePoint tab and EMS tab and submit a case study, and we'll talk through it. But thanks again, Cap. We appreciate you. We'll see you guys next week.
Awesome. Thanks, Chief.